Okay, so we'll get started. Hello, everyone. Welcome to our research webinar series. Today's presentation will be hosted by Michael Ravenek on adjusting to life with young onset Parkinson's disease. Michael Ravenek is in the final term of his doctoral studies at Western University in the Health and Rehabilitation Sciences program. Chronic neurological disease, including Parkinson's, has been a primary focus of his research throughout his academic career. If you have any questions during the presentation, please feel free to type them in the chat box that should be on the right-hand side of your screen, and Michael will try to get to as many as possible at the end of his presentation. With that said, I'll now pass it over to you, Michael.
Perfect. Thank you very much. Hopefully everyone can hear me well. Alina, can you just confirm that you can hear me? Perfect. All right, so, pardon me? All right. So before I get started, I would just like to acknowledge the Parkinson Society Canada and the Canadian Institutes of Health Research who provided me with the Doctoral Research Award to conduct the research that I get to talk to you about today. I'd also like to thank the Parkinson Society Southwestern Ontario who provided support for my research in terms of doing things like helping me with recruitment and providing me with some space at their conferences and seminars to collect some of my data. And I'd also like to thank the Parkinson Society Ontario for giving me the opportunity to speak with you all today about my research. So just to provide you with a brief outline of what we're going to be talking about today, I'm going to start off just by providing a basic overview of Parkinson's disease and what is young onset Parkinson's disease. And then I'm going to move in to talk about my study in terms of its purpose and its methodology, but I won't spend too much time on that because the primary focus today is to talk about the adjustment process, or what I was able to really learn from my participants in terms of how they adjusted to living with young onset Parkinson's. And so in describing this adjustment process, I'll also describe what it was that individuals were adjusting to, as well as the different strategies that they used to build their resilience in this adjustment process. Now, two of the products that have came out of the research that I've completed are advice booklets for individuals who are newly diagnosed with young onset Parkinson's and for physicians who are responsible for providing care and treatment to those living with young onset Parkinson's. So I'll talk a little bit about those near the end of the talk, and I'll also provide some information about some additional research that we're going to be doing with the booklets in the near future. And as Alina said, at the end of my talk, I'll try to answer any questions that have been typed up on the right-hand side in the chat box. Okay, so to begin, what is Parkinson's disease and what do I mean by young onset Parkinson's disease? So as I'm sure as many of you know, Parkinson's is a progressive neurological disease. It's characterized by progressive functional decline over time, and that progressive decline is caused by the loss of dopamine-producing cells in the midbrain. Midbrain nucleus called the substantia nigra. Now, because there's currently no cure for Parkinson's, treatment is based on medication regimens and also rehabilitation, so things like occupational therapy, physiotherapy, speech-language pathology. Now, those loss of dopamine-producing cells in the midbrain nucleus produce very specific motor symptoms, and those motor symptoms are what referred to as cardinal motor symptoms, are what physicians use to make a clinical diagnosis of Parkinson's, and we use the acronym TRAP to remember what those cardinal motor symptoms are. T standing for resting tremor, R standing for muscle rigidity, akinesia, which refers to the absence of movement, and we typically see things like the lack of facial expression and reduced or absent arm swing during walking as typical representations of akinesia, and P standing for postural instability, as Parkinson's disease is a significant risk factor for experiencing falls. Now, in addition to these cardinal motor symptoms, there's also growing awareness that Parkinson's is not just a motor disease. There's also non-motor symptoms that are associated with Parkinson's. And so I've created and like to use the acronym SCAN to remember these non-motor symptoms. S standing for sleep and sensory difficulties. So sleep difficulties including things like restless leg syndrome or REM sleep disorder. They can occur very commonly in Parkinson's. Sensory disturbances include things like changes in one's sense of smell, changes in vision, and pain is also a sensory disturbance that can occur within the context of the disease. C stands for cognitive difficulties, and we primarily see this in terms of frontal lobe functions and executive functions. So things like planning and attention and visual spatial functioning or being able to navigate one's environment. Those are some typical cognitive difficulties that can occur. And according to the literature, approximately 30% of those who have Parkinson's disease will eventually develop dementia. A stands for autonomic difficulties, and autonomic refers to a specific part of the nervous system that's responsible for controlling our bowel and bladder, as well as a number of other bodily functions. And so autonomic difficulties in Parkinson's include things like bowel and bladder dysfunction. So, for example, constipation is a common non-motor symptom that can be associated with the disease. And N stands for neuropsychiatric difficulties. And all I mean by this is that things like anxiety and depression are again very common in the experience of Parkinson's. Now, although I've described these different motor and non-motor symptoms, it's also very important to emphasize that the condition is very heterogeneous. It's individual from person to person, meaning that not everyone is going to experience all of these motor difficulties or all of these non-motor difficulties. And so that's very important to keep in mind. And so if that's Parkinson's disease, then what is young onset Parkinson's disease? And there's three main ways that we differentiate between young onset Parkinson's and the other subtypes of Parkinson's disease, the most obvious being the age of onset. And so the literature describes three different subtypes of Parkinson's. There's young onset Parkinson's, juvenile onset Parkinson's, and regular onset Parkinson's. Now, when a diagnosis is made between the age of 21 and 55, that's typically what is referred to as young onset Parkinson's. Prior to the age of 21 is juvenile onset, and after the age of 55 being that regular or later onset subtype. And approximately 80% of cases of Parkinson's that do occur after the age of 55. So young onset Parkinson's and juvenile onset Parkinson's are very much less common, accounting for collectively only 20% of Parkinson's cases. Now, young onset Parkinson's is also differentiated from the later onset subtype of the disease in terms of the actual physical experience. Typically, young onset Parkinson's is described as being slower progressing compared to that later onset subtype. However, there's also higher rates of dyskinesia, dyskinesia being a side effect of the Parkinson's medication, which really describes that jerky and involuntary movement that you may sometimes see. And certainly when Michael J. Fox is giving a television interview, he'll often display dyskinesia, where he's very jerky with his movements, both in his upper body and lower body. And so younger people do tend to be more sensitive to the Parkinson's medication. Now, probably the most important difference is in the actual psychosocial experience that is really related to the age which the disease has occurred. So definitely individuals with young onset Parkinson's are at higher risk of experiencing employment disruption. And there is some literature that actually suggests that almost everyone who develops young onset Parkinson's will have to leave the workforce within 10 years of their original diagnosis. So employment is certainly a big issue for individuals living with young onset Parkinson's, and we'll talk more about that in the context of the results of my study. Individuals with YOPD are also at higher risks of experiencing family life disruption, so being able to fulfill some spousal roles and parental roles becomes much more difficult, and so there's higher rates of marital dissatisfaction, for example, and greater rates of sexual relationship dissatisfaction. In addition to these, individuals with YOPD also experience greater rates of perceived stigmatization, again, because 80% of the cases typically occur later in life. And so a 26-year-old who develops Parkinson's disease, it becomes difficult to sometimes describe to other people what disease they have, and again, because it's typically seen as a disease of older age. In addition to that, the stigmatization is also related to the idea that a lot of the Parkinson's symptoms and side effects from medication can also mimic things like substance abuse disorders, like alcoholism, for example. So while in public, individuals may be thought to be drunk, for example, which is certainly not the case. On top of this, individuals with young onset Parkinson's also have 2 times the rate of depression in comparison to those who develop Parkinson's later in life. And so depression is common across individuals who have Parkinson's disease, but when it's developed younger in life, the rates are actually twice as high. And so all of these factors together contribute to greater declines in quality of life, again in comparison to individuals diagnosed later in life. And so now I'll move on and talk about what it was that I did with individuals living with young onset Parkinson's. And so the original purpose of my study was really to understand how and why individuals living with young onset Parkinson's acquired health information related to their disease over time. This hadn't been done before, which was quite surprising, and it has a very important practice implication in terms of how can health professionals, whether it's physicians, OTs, PTs, nurses, as well as others involved in providing care to those living with the disease, so the different regional members of the Parkinson Society of Canada, for example, how can these people best provide education about young onset Parkinson's disease to those who come to be diagnosed? And so I originally started, as I just mentioned, really looking at information seeking, but the purpose of my study changed over time. Because I very quickly saw that information seeking was very closely tied to this idea of adjusting to the disease. So I had to broaden my focus. And in doing so, I understood that health information seeking and learning about Parkinson's was really one strategy that individuals were using to build their resilience to the loss of control that they perceived and really helped them in the adjustment process. Now, in addition to health information seeking, there were also what I referred to as internal strategies and external strategies. And so the second half of my talk is going to focus on these different strategies. Internal strategies essentially being more cognitive-based strategies. So, for example, individuals would change their beliefs and perspectives about certain things in their lives, again, to be more resilient. And with respect to external strategies, that more refers to relationships that individuals had with other people and the way that they express themselves to other people. So just a little preview of some of what we're going to talk about a bit later. So the first part of my results that I'll talk about is that adjustment process, and the second half focusing on the resilience strategies. But before I get to that, I just wanted to mention the specific methodology that I used. So this was a qualitative study, and I used grounded theory methodology. And it's essentially exactly as it sounds, where working to develop a theory that's grounded in the data that I've collected. And so I love to use the tree metaphor when I describe grounded theory to anyone, because it essentially allows one to think of the leaves and the branches of a tree as being kind of the theory that has developed out of the data or the root system of that tree. And so within my study, I collected both elicited data and extant data. And essentially that's just a fancy way of describing that with the 39 individuals who took part in the study, we did things like one-on-one interviews multiple times. There was also an online discussion board that individuals could take part in. And there were also 6 focus groups that I conducted over the course of my data collection. So that was the elicited data that I did, data collection that I did with the 39 individuals living with young onset Parkinson's who took part in this study. Now, in addition to that data, I also collected what is referred to as extant data, or data that pre-exists without me really influencing its construction. And so I went out and found a number of autobiographies written by individuals living with young onset Parkinson's disease, and ended up including 14 of those as additional sources of data within my study. Okay, so now I'll move on and start to talk about the adjustment process. And so in talking about the adjustment process, it's important to understand, first of all, what it was that individuals were adjusting to. And so the core category of my grounded theory, or that concept around which everything else seemed to revolve, was managing uncertainty. And individuals experienced uncertainty in their lives with respect to their functioning, as well as their identities. In terms of functioning uncertainty, for example, after diagnosis, individuals didn't know what was going to happen with the physical progression of the disease, whether or not they were going to develop any cognitive difficulties like dementia. So there was a lot of fear that came with that uncertainty of the future, because, again, it can be a very individual condition. And so there's uncertainty in terms of how it's going to progress in the future. Now, even in the day-to-day experiences of individuals, there was also functioning uncertainty. And individuals often use the phrase having good days and bad days to describe that uncertainty, not really being able to tell whether or not any given day was going to be a good one or a bad one. A good day being a day where individuals felt more in control of their symptoms and experienced less symptoms. And a bad day being the opposite, where individuals experienced more symptoms, had more difficulty feeling as if they were in control of their bodies. Now, even beyond looking at day-to-day difficulties, there were also hourly changes in functioning and uncertainty with respect to those hourly changes. And this refers more specifically to that on-off phenomenon that can occur with Parkinson's medication, where really the on phase representing where the amount of dopamine in the central nervous system has been maximized, and an individual is at risk for experiencing some of those side effects, and the off phase being that wearing off of the medication, and the symptoms of Parkinson's tend to come back in between dosages of medication. So in addition to functioning uncertainty, I mentioned there was also identity uncertainty that individuals described. And so this occurred with respect to employment, as we saw with some of the literature that's already been done on young onset Parkinson's disease. And so individuals were uncertain in terms of whether or not they were going to be able to continue to work with the disease into the future, uncertain whether or not they had to disclose their diagnosis to their employers. Difficult issues like that, and employment is certainly very much important to our identities and how we see ourselves and how other people see us. Individuals also experienced uncertainty with respect to their family life, again, not knowing whether or not they were going to be able to fulfill some of those parental roles or spousal roles. So things like going on family vacations or going to children's graduations or being able to walk them down the aisle when they get married. There was a lot of uncertainty with respect to playing some of those roles within their families. And another important aspect of identity is really seeing ourselves as independent individuals. And so there was also uncertainty with respect to the amount of dependence that an individual is going to have, for example, for completing self-care activities and things like that. So that was the uncertainty, and really individuals were adjusting to or managing with that uncertainty in their experiences. And so there were two main levels of adjustment that my participants and I had kind of talked through and were able to put onto paper. The first being logical adjustment, and the second being more emotional adjustment. And each of these levels of adjustment ranged from greater denial to greater acceptance. And I know that some people don't necessarily like those terms, denial and acceptance, but I felt it was important to include them because these were the words that my participants were using to describe their experiences. But instead of just taking them at face value, I looked more deeper into their experiences and found out that there were these two different levels that individuals were experiencing. This logical adjustment process and the more emotional adjustment process. So the logical adjustment process was very much a reasoning process where individuals were weighing the evidence that they did in fact even have young onset Parkinson's disease. And I saw this as serving a very much a protective function in that individuals didn't want to necessarily accept right away that they had the disease because of the potential implications the disease had for their functioning and their identity. So it wasn't a bad thing that they were experiencing denial. In even emotional denial, it's not a bad thing. There's often, a negative association with the term denial, but from what I saw, these different parts of the adjustment process served different functions. And so I'll describe that a little bit more as we move through. And so after this logical adjustment process, individuals subsequently entered in a more emotional adjustment process where they started to work through some of that grief that was associated with now logically accepting the idea that they had young onset Parkinson's. And so over time, as individuals came to some degree of emotional acceptance, we saw that they started to actually redefine and even reset what gave them meaning and their priorities in life. And so over the next few slides, I'm going to look at these two levels of adjustment in a little bit more detail, starting with logical denial. And so I've kind of overlapped the two continuums of logical and emotional adjustment on the left-hand side of the screen here. And so, again, I'm going to work through these four different aspects of adjustment that my participants described. And so the amount of time that individuals spent in any one of these parts of the adjustment process varies greatly, as we'll see. And so that's an important thing to keep in mind as I'm describing this is, not everyone necessarily experienced all four of these different stages or phases, whatever you'd like to call them, but for the most part, in most of the experiences of individuals, they were there. We were able to identify them. And there's also a color gradient that I've used, and that'll describe a little bit again as we move through these stages, where the lighter blue refers to the idea that individuals spent less time in that part of the adjustment process, and the darker blue, which we'll see more in a couple of slides, especially with the emotional adjustment, represents the idea that individuals spent more time in that part of the adjustment process. So with respect to logical denial and how individuals were using or acquiring health information, we saw that there was generally either an avoidance of health information related to Parkinson's during this time, or conversely, individuals were seeking out health information to try to find some alternative explanation to what their difficulties could be. And so during this time, we also saw that individuals were seeking out multiple medical opinions, not really accepting or necessarily wanting to accept or agree with that first physician who told them that they had Parkinson's disease. So they went out and again sought out other opinions from doctors. And so for each of these 4 different levels, I do have a small passage from either an interview or a focus group session that I conducted with my participants. And any names that you see are pseudonyms, which are false names to protect the identity of individuals. And so I asked Trevor, and again this being representative of logical denial, I asked him, so what was the purpose of collecting all of that information about Parkinson's disease? And he said, I was really looking for an alternative to Parkinson's disease, I think, in many ways. I was struggling just to come to terms with the idea that I could possibly have PD. If I was looking for information on PD, it was almost a proof that I didn't have PD. So again, that idea of seeking out health information to disprove the diagnosis and try to find some other explanation. Over time, however, individuals did come to logically accept this idea that they had the disease. And eventually this was facilitated by the evidence and the reasoning that they did. And so, for example, the second and third and fourth medical opinions that they may have sought out confirmed that they had young onset Parkinson's disease. The health information seeking that they did also helped to confirm that they had the disease, in that they were able to see the symptoms that they were experiencing and what they were reading about the disease. And in some cases, individuals were prescribed medication for Parkinson's after they were initially diagnosed. And when that medication helped to improve their function, that also helped with the logical acceptance process, in that if Parkinson's medication is helping me, then this must be what I have type of thinking. And so here's another passage to illustrate logical acceptance. So Danny said, I had started doing the research a little bit and finding information. Like the sense of smell thing, I didn't realize. I knew that something was going wrong in that area for months, but there wasn't the correlation of it. I'm going, yeah, I don't think I've been able to smell things for months. And the handwriting was something else I read up on. Oh wow, this is me to a T. The restless leg was sort of what I had, maybe not quite. There was enough similarities that I'd say, yeah, every point was almost like bang on. So again, in helping Danny come to this idea of a logical acceptance of the diagnosis, actually reading about the disease and seeing some of the symptoms and difficulties that he was experiencing helped with that logical acceptance. Now, when individuals logically accepted the disease, they subsequently started that emotional adjustment process. And for most people, that started in emotional denial. And emotional denial was not the absence of emotions, but instead one's response to the functioning and the identity uncertainty with which they were now confronted in accepting the idea that they had young onset Parkinson's. So there were 2 parts of emotional denial. There was an emotional element, and there was also a behavioral element that I'll describe in a couple of minutes. But the emotional element was very much characterized by individuals asking the question, why me? In asking that question, why me, it told me that they had logically accepted that, okay, I now have Parkinson's, but why me? And so they hadn't yet started to really emotionally reconcile what the disease meant for them in their lives. And so emotional denial was very much also characterized by anger and depression that individuals felt. And so another passage here just to illustrate for us this part of the adjustment process. So Susanna says, I was just angry that I had to deal with it. Angry that it was hanging over my head at the prime of my life. And I think that's what happens with young onset patients, is that it affects us when we're at the prime of our lives. We might have young families at home, or we're just at the peak of our careers, or we're going to try to become financially established. And to have to deal with what I felt was really more of a nuisance than anything. It made me angry. And so as I mentioned, there was also a behavioral element to emotional denial, and more specifically, an avoidance behavior or social avoidance, where individuals talked about building up walls around themselves and hiding their symptoms from other people. And this was especially the case if individuals were still working and weren't really sure whether or not, again, they needed to tell their employers that they had the disease. And so very much feeling that they needed to hide their symptoms so that they wouldn't get fired. So again, it very much served a protective function, just like the other parts of the adjustment process. And so Lily describes how I was hiding it for survival, for keeping my job. I knew I had it, but I just didn't think that anybody needed to know I had it until it was necessary. And I just kept it to myself. I just went way out of my way to make sure that no one could tie me into it. And that lasted for, well, I'd say I did it for 10 years. So again, I described a couple of minutes ago how the different parts of this adjustment process was very individual, and that some individuals perhaps were able to navigate this emotional denial within a couple of weeks or a couple of months after their diagnosis, and others, for various reasons, took upwards of 10 years. And in some cases, individuals took even longer than 10 years. So again, I can't emphasize more that just like Parkinson's disease itself is individual to each person, so is the adjustment process. And so kind of over time, individuals were able to navigate that grief that they experienced, the anger and the depression with asking, why me? And they started to come to some degree of emotional acceptance. And so I've kind of used the bidirectional arrows in the graph on the left to illustrate that this was an ongoing process. It was never fully complete, and emotional acceptance could never really be complete because Parkinson's is a progressive disease. So regardless of where a person is in the disease process, over time there is still the potential, that threat, that additional changes to one's functioning and additional changes to one's identity could still occur. So it was very much ongoing. In addition to that, it's very important to emphasize that emotional acceptance and emotional adjustment in general was not a passive process. Individuals couldn't just experience the disease in the passage of time and experience this level of acceptance, because there was a lot of emotional work that individuals needed to do in coming to accept the disease in their lives at that more emotional level. And so this is where the different resilience strategies come in that I'm going to talk about in the second half of my presentation. But there were also two components that helped to characterize this idea of emotional acceptance. The first being that individuals saw that they could start to be proactive in their lives, that they didn't just have to be passive bystanders to what the disease was doing to them. There were things that they could do personally to take back some measure of control in their lives. So Sandy describes how acceptance does not mean I have passively resigned myself to the fact that I have Parkinson's disease and must bravely endure the consequences. Instead, acceptance implies that I have become well informed on the subject of Parkinson's disease so that my symptoms can be best managed. Again, helping to illustrate here the very supportive role that health information seeking and knowledge about Parkinson's disease played that, again, we're going to talk about shortly. And so the second component of emotional acceptance was that individuals started to kind of redefine their identities as now being someone who lives with young onset Parkinson's disease. And this was very much facilitated and easier when individuals were able to take up roles in the Parkinson's community that mimicked some of the roles that they used to play in their careers but had to give up. So, for example, advocates and educators may have used to been teachers or healthcare professionals, where there was very much that education role in what they used to do. So Susanna describes, as an advocate, I talk about empowering yourself and accepting the diagnosis. I also feel useful in terms of my career because that was a big thing that I enjoyed, was that contact with people and educating them. So I felt a great loss when I had stopped work. So being able to reach others that are looking to me as a resource for them sort of validates that need in myself. So those were the four different, again, either stages or phases, whatever you want to call it, of adjustment. But now we're going to take a closer look at those specific strategies that individuals used in their lives that helps them make that adjustment. And so again, this is primarily referring to what is happening in the emotional adjustment process, where individuals are experiencing that uncertainty with respect to their identity and their functioning, and they're perceiving having lost control over their bodies and their identities. And so they drew on these different strategies that I'm going to discuss as a way to increase their perceived control in their lives. And so there were three categories of resilient strategies. There were those internal strategies, or those more cognitive strategies, where individuals were changing beliefs and perspectives about life and about the disease. Learning about Parkinson's and developing a base of knowledge about the disease also was a resilient strategy. And finally, the external strategies, where individuals were changing the relationships they had with other people and changing how they express themselves to other people. And so we'll talk about these over the next, 20 minutes or so. And the last arrow there just illustrating that increased perceived control feeds back into the adjustment process, again helping individuals to stay somewhere within this emotional acceptance. So we'll start with the internal strategies first. And so the first internal strategy was this idea of making social and self-comparisons. Social comparisons essentially describing the idea that individuals would make comparisons to the experiences of other people, either that they knew or didn't know, and self-comparisons being the idea that individuals would also make comparisons to previous experiences that they themselves had lived through. So, for example, it was very common to describe the idea that it could be worse. And so this describes that individuals were constructing an illness hierarchy, where the hierarchy was built around potential disability and mortality that can result from any given disease. So comparisons to things like ALS and MS and cancer and things like that were often positioned as being worse things that they could have in terms of a neurological disease, and that facilitated a less threatening perspective of having young onset Parkinson's disease. And so again, minimizing that perceived threat that was caused by the uncertainty of identity and functioning, helping to increase one's resilience. Another social comparison that was made was in reference to the idea that health uncertainty is very much a universal phenomenon. No person, whether or not they have young onset Parkinson's disease, knows what tomorrow is going to bring. And so a lot of people took refuge in that idea that really young onset Parkinson's was just part of what they had to deal with as part of their uncertainty, but uncertainty is common to all of us. And with respect to more self-comparisons, certainly if individuals were successful in previously overcoming a serious illness in the past, for example, some participants overcame things like cancer prior to being diagnosed with Parkinson's disease, they were able to draw some strength from being able to successfully overcome something that was more of a threat to their mortality. And so they didn't see Parkinson's disease as something that was as difficult to have to manage with. And so here's a passage, again, to help illustrate this idea of social and self-comparisons. So Sandra said, "It could have been worse. I could have came out of there with an MS diagnosis, which I consider to be worse, in my opinion, an ALS, multiple systems atrophy, a brain tumor, like I'm down here, with Parkinson's." And so I asked her, "Why do you think you made that comparison? What did it mean for you to do that?" And she said, "I guess it was basically level of disability and level of mortality, MS, the people I know are a little bit more seriously ill. I guess there's lots out there that aren't, but the ones I know, and ALS, well, it speaks for itself, and multiple systems atrophy isn't much better." So again, for her, it very much helped her in being resilient by comparing Parkinson's disease to what the diagnosis could have been, being more serious diagnoses like ALS on that mortality and morbidity scale. Now, the second internal resilience strategy that individuals used was the idea of changing one's time perspective. So within the context of our Western culture, we very much value thinking of and making plans for the future. What we're going to do, for our next summer vacation, or what we're going to do when we retire. And so the future was a source of fear and uncertainty for individuals because they didn't know what their futures with young onset Parkinson's disease was really going to mean. And so as a way to regain a feeling of being in control of their lives and increase their resilience, individuals spoke of focusing on and living more in the present as a strategy to manage with that fear and that uncertainty. Enjoying life more now and not waiting to do things on their bucket list. And so this really reduced what individuals felt like they would potentially lose from the disease if they took advantage of today and did everything that was important to them today. It really minimized what they could potentially lose. And so, although this was an important strategy that individuals used, it could sometimes cause difficulties in spousal relationships if the spouse who didn't have Parkinson's disease didn't share that change in time perspective, and where they were still living more in the future and thinking about all of the potential problems that could occur. And so for those relationships that were stronger, it was really when both the person with Parkinson's and the spouse came to see the importance of taking advantage of the present and living in the present as opposed to focusing on the future, which was a source of fear and uncertainty. So Alicia says, "I think that focusing on the present just doesn't make you get so overwhelmed with life in general and jumping too far into the future, which is the unknown, because this disease is different for everybody. So you don't know in 5 years what you're going to be dealing with. I think it's too overwhelming to look at the future. So I think it's better just to stay within your own focus of what's going on with you and stay positive with that and deal with that. I think it's better than jumping too far into the future." And so the third internal resilience strategy that individuals used was this idea of drawing on spirituality. And spirituality was very much broader than religion, although religion could be part of that. And I saw this throughout all of the different autobiographies that I read and in many of the experiences of participants who took part in this study. So for example, in Michael J. Fox, in one of his autobiographies, he talks about spirituality and faith as being that third leg of the stool on which he's sitting, without which he would fall on his butt. It was described a little bit differently by some participants in my study who looked at spirituality more in the sense that the disease wouldn't be with them as part of their soul in the afterlife. And so, for example, Martha talked about how it's not in my soul, it's just here. And this is like a recyclable container, being more referring to her body. And so I asked her, so how has that helped you? And she said, I think that turned the corner of the denial. Yeah, absolutely it did. I can't tell you what year or when that was. It's more recently. It's been more than a year or two. It's just like, oh, hey, wait a minute. This is just like something I have to go through right now. But it's not going to be, like it's not adhered to me as a person, like as part of my soul. And I guess another important thing to emphasize that I haven't mentioned yet is that not every participant or every autobiography author used all of these strategies. Again, it was very much individual as to which strategies were used, but I saw them all as helping individuals to build their resilience to the disease and help them come to that move through emotional adjustment more towards some degree of emotional acceptance. So those were the internal strategies, and so now I'm going to move on and talk about the different external strategies that individuals used. And again, these were changes that individuals had made in the ways that they expressed their emotions and they interacted with others in society. So as opposed to internal strategies, which were more cognitive, external strategies were more behavioral in nature. So the first external strategy that individuals used was writing. So really by getting their emotions onto paper or on to the computer screen, it externalized those difficult emotions that they were dealing with. And so a lot of the different authors and people who used this strategy in their own lives saw that it didn't only have the potential to help themselves, but it could also help other people as well. So not only being proactive within their own lives, but being proactive in the sense of helping the Parkinson's community more generally. So individuals talked about writing things like poetry and books. For example, there were the 14 autobiographies that individuals wrote. Some individuals had blogs and others wrote journals. And again, some of these things were more private and just helped individuals on their own level with adjustment, but in some cases they were shared more publicly, like the autobiographies. And so one autobiography author, Richard Wenmouth, describes about his autobiography that my wish is that my story will bring hope for other young sufferers. There is light at the end of the tunnel. There is no denying that it has been a tremendously difficult journey, but you can and will get through it. So that was writing. And the second external resilience strategy was the idea of pruning negative relationships, where essentially individuals talked about picking and choosing those relationships that they wanted to keep because they were supportive and ending the other relationships in their lives that were more draining, made it more difficult to be resilient to now having experienced Parkinson's disease. So Shauna describes how knowing that it's here and that it's not going away, it sort of made me look at everything with work and friendships and relationships. It makes you start to think about what it is that you really want, and that sort of makes you happy and kind of clear the clutter. Like I had a couple of friendships that would suck you dry and not letting all of the small stuff clutter you because you don't have time for it. And the people that are complaining about I didn't sleep last night, I sit there and I think, if you only knew what I had to deal with every day. You've only got so much time and so much energy, and you definitely have to pick and choose. So again, that was the idea of pruning negative relationships from their lives to make them more resilient to the disease. And the final external strategy was drawing on social supports. And so these supports varied greatly from person to person, but often involved drawing on other individuals who live with Parkinson's disease, either on an individual basis or in support group settings. Some individuals spoke with and became friends with other individuals who were dealing with a serious health issue that was not necessarily Parkinson's disease. And of course, many people also drew on the Parkinson's Society Canada and the regional offices across across Ontario, again, as a source of support. And so drawing on these supports helped to normalize the experiences that they were having with the disease, and also helped to lift a burden that they may have been feeling in trying to keep the diagnosis to themselves and kind of really only telling those within their very close network of family members and friends. And so, again, just a passage here from Susanna to describe this strategy. I didn't think that hiding the disease and hiding my diagnosis and trying to pretend like everything was fine and putting on that happy face that I had done for so long, that mask that I had worn for as long as I'd worn it, I didn't think that was a burden until I let it go. Until I started to disclose to my family and my friends and other people that I had this issue. That I had felt such a burden being lifted from me that I really didn't know it existed prior to that disclosure. So again, those were the different external strategies that individuals used to build resilience. And so now we'll move on to talk about the final strategy that individuals used, and that was learning about Parkinson's and developing that base of knowledge. And so in developing one's base of knowledge about Parkinson's disease, some individuals actually had knowledge of the disease prior to their actual diagnosis. For example, some individuals may have had family members or friends who had the disease, and so they knew a little bit about it from that. And others may have had classes or lectures on Parkinson's disease as part of their formal education. So in varying ways, participants came to their diagnosis with different amounts of knowledge about what Parkinson's disease was. And so after one's diagnosis, individuals collected information from hundreds of different sources, perhaps even thousands of different sources. And so I categorized these sources of information according to either being extant sources or elicited sources, really differing in the degree to which those sources allowed one to interact with that information. So extant sources were more static sources, things like print materials or static web pages that you read, but you don't really interact with. You can't ask specific questions of a book. It doesn't talk back to you. Whereas elicited sources are things like people or groups that are either in person or virtual that you could talk with directly. So things like healthcare professionals or other individuals who live with Parkinson's disease, and you can ask them specific questions. And so these different sources of information were used both in an active sense and a passive sense. Actively, when a person actively sought out information from one of those two types of sources, and passively referred to either someone else providing that book about Parkinson's or providing information in some other way. A passive elicited source, I guess the best example that I could give would be when individuals were either in an in-person or a virtual support group, and they weren't really contributing to the discussion, but rather taking in what was being discussed. So again, it was more of an elicited source, but being more of a passive acquisition of that information. And so both the knowledge that a person had prior to their diagnosis, in addition to what they had acquired after their diagnosis, resulted in kind of an accumulated base of knowledge that a person had at any given point in their experience, whether this was 1 week post-diagnosis or 15, 20 years post-diagnosis. And so what individuals did with that accumulated knowledge was they filtered it through their own experience living with the disease to make it more specific to them. We talked about how Parkinson's disease is individual to each person, and so these strategies that are going to work for a person in terms of maximizing their function are also going to be individual. They may work for some people and not for others. And so we accumulate this basic knowledge, but won't really know what's going to work best for us until we try it ourselves. And so I've referred to that highly idiosyncratic and specific knowledge as experiential knowledge that an individual held once they filtered what they had learned through their own experience. And so often this filter, or this using one's bodily experience with the disease, was described in terms of using trial and error strategies, or experimentation is also a frequently used terms in describing this process, and was very common with things like lifestyle management strategies. So things like trying different exercise regimens, or changing up a person's diet, avoiding certain foods or incorporating other foods. Things like medication dosages as well requires a bit of trial and error and experimentation. So it occurred in a number of different areas, but essentially individuals were accumulating this knowledge from all of those sources and then filtering it through their own experience to see what was going to work for them, or that experiential knowledge. And as well, the passage of time also kind of acted as a filter, because again, that highly unique experience of Parkinson's disease, regardless of whether or not you do anything, over time, the disease would progress. And so individuals would come to know more about what their own experience with Parkinson's disease was going to be like, what symptoms they were going to experience and side effects they would experience, things like that. And so more specifically, in reference to health information seeking, we were able to identify two main types of information seeking. There was general information seeking and specific information seeking. General referring to, well, more general information about the disease, so causes and treatments and symptoms, things like that. Whereas specific information seeking was more specific to functional issues that individuals were dealing with at a given point in time. So whether they were having concerns about their driving ability and were looking for a driving rehabilitation program, or having difficulty with sleeping difficulties and looking for information on that. So those were the two main types of information seeking. And as I described just a couple of slides ago, there were two main types of information sources that individuals drew on in accumulating their knowledge. There was those extant sources that you couldn't really interact with, and elicited sources that you could interact with directly and ask questions of. And so when information seeking started, typically during that logical adjustment process, information seeking tended to be more general in nature, and typically individuals used more extant sources to find that general information. And over time, during the emotional adjustment process, that's when individuals started talking to other people living with the disease and started talking to other healthcare professionals about specific issues that they were dealing with. So again, those were the three main resilience strategies that individuals used in helping them to emotionally adjust to living with young onset Parkinson's and the uncertainty that was part of that experience. And so just the final thing that I will touch on before I'll answer any questions that anyone has is the advice booklets that, again, were products that came out of this research where I worked with my participants in both the interview settings and some of the focus groups, where we allocated specific time to talk about what advice they had for others who are just newly diagnosed with the disease, as well as what advice they had for physicians who are responsible for caring and providing treatment to individuals living with young onset Parkinson's. And so these are the covers of the two books, and they are freely available right now on the Parkinson Society Canada website. If you go into the section of the website that talks about young onset Parkinson's disease. But it's also important to note that these are not finished products. In fact, I'm currently working with the Parkinson Society Canada to do a national survey of these booklets, and we are hoping to get this survey out to people sometime in June. So the survey would be available through the PSC website, will also be advertised through social media and through different mailing lists. And I'm assuming that those mailing lists would include the different regional offices as well, because we want as many people as possible to participate in this survey to provide us feedback on these booklets in terms of their need, their usefulness, and any additional advice that you guys may have in terms of things that may be regional specific to a certain part of Canada, or advice that maybe you thought was important that was missed in the booklets. Because again, these booklets were created with my participants and are specific to the advice that they had. So we continually want to improve all of the resources that we generate. And so the second version of these booklets hopefully would be available later in the fall. And so what we would do is incorporate the feedback that we receive from people. We're also going to do a French translation of the booklets so that the booklets are available in both official languages. Some of the staff at the Parkinson Society Canada are also going to take those booklets and present them at a healthcare professionals conference later in 2014. And I'm going to work on putting together a journal article that talks about the generation of the booklets and their content, and hopefully have that published in an academic journal sometime in 2015. So that's kind of the plan for the booklets, and again, I very much encourage all of you who are listening in to take part in this survey in June when it becomes available. The survey is not just for people living with young onset Parkinson's, but is also available for spouses, for healthcare professionals, really anyone who has some feedback to provide. We would love to hear it. And so that is the end of my webinar, and I've just provided my email address here if anyone has questions that they don't get to ask or I didn't get a chance to answer. You can certainly connect with me using my Gmail address. So thank you very much.
Okay, and I think we have one question over here from Wendy. She wants to know if YOPD is more common in men or women.
YOPD, just like regular or later onset Parkinson's disease, is it's pretty close, but based on the literature that I've read, there's slightly more men who develop young onset Parkinson's disease.
Okay. And I think that's all we have for questions. So thank you so much, Mike, for the presentation. It was really insightful. We hope that you all found the information helpful and valuable as well. Thank you for joining us, and have a lovely rest of your day. Thank you.
Thank you.